If you have a patient with anemia and all of a sudden you have a sight on his RFTs and you notice that his creatinine is normal on a background of a very high urea or disproportionately high urea, you must be highly suspicious of an ongoing upper GI bleed.
If a patient presents to you with jaundice, specifically hemolytic jaundice, and the patient also has signs and symptoms of peripheral neuropathy, specifically ataxia, always keep a high suspicion of vitamin E deficiency.
You are sitting in OPD and you encounter a patient with isolated thrombocytopenia and there is no lymphadenopathy, no splenomegaly. It's ITP until and unless proved otherwise.
LT to LDH ratio is a non-invasive test, or it is used to differentiate between ischemic hepatitis, typhoid hepatitis, and viral hepatitis. If it's more than 9, it's more in favor of viral hepatitis. If it's less than 9, it's in favor of typhoid hepatitis. And if it's less than 1.5, it is always ischemic hepatitis.
If you have suspicion for a cryoglobulinemia, you must always look for this triad, that is weakness, arthralgia, and palpable purpura, which is Melzer triad.
If you are highly suspicious of leukemia in a patient and there are no lymphoblasts on peripheral smear of the patient, it is always worth checking it with the bone marrow biopsy of the patient, because it might be a typical presentation of aleukemic leukemia in which there are no lymphoblasts on the peripheral smear and there are lymphoblasts on the bone marrow biopsy of the patient.